I think we have most suitable person for and giving us the knowledge of the palliative care, and um, uh, this session will cover the general principles of palliative care. So Dr. Rajagopal, who is my who is the director of Trivandrum Institute of Palliative Sciences as well as the chairman of Palliative India. He has been in the field of palliative care since maybe from late 1980s, and actually he with his colleagues started the first community supported palliative care unit in Calicut. So he, I think he doesn't need any introduction, and he is also a Padma Shri awardee. So I welcome sir to the session. Sir, it's over to you.
Thank you, Sunil. Thank you, Sri. Hello, everybody.
Good evening, sir.
Good evening.
Good evening, sir.
Good evening. It's very awkward when we are. There are several familiar names and faces. Kamin Kumar, I see you. But it's very awkward to start without any introduction. Speaking to blank screens and unknown faces, very awkward. But I also realize that we may not have enough time for the session if we have self-introduction. So, Sunil, are we planning it without a round of introductions?
Sir, we have about 100 participants, so 77 has now joined.
Okay.
So it will not be possible.
Okay, it is just not practical.
So that's the.
Okay, that is a sad part of it. But on the other hand, how gratifying that more and more people are coming forward to learn, to relieve suffering. Fantastic. Nobody in this group, if you have been educated within India, medical education in India, has had a formal education in palliative care as part of your MBBS or BDS. It's only in 2019 that this subject became part of MBBS curriculum. Some of you may have studied by yourself or undergone courses already. I see Ashok Matthew here, who has been practicing palliative care for I don't know how long, at least 15 years. And the group, therefore, has a varied composition. Jagrati, I see you there. I'm taking this course for the 7th time. I don't know. Okay, but so gratifying. Thank you. Partly because everybody, so many people are doing their global fellowship and becoming part of it. So people like Amrita and Sairu, who have been teaching these courses for about a century, are also here as participants. That's good because we can all share knowledge as we go along. So apologies to the veterans. Some of this will be boring for you, talking about the same things all over again. Because the size of the group, it may not be possible to get your responses. The interaction may be limited. But I still want you to think your own answer to the question that I am going to ask. In this group, if there are 100, at least some 30 would have the experience of going through someone in your own family going through a serious illness. And to those people, I want to pose this question. Do you think the medical system primarily looked at the disease, or also at your suffering. When I say your suffering, I mean the suffering of the person with the illness as well as the family. If there are 100 people, there will be at least 1 or 2 people who have gone through themselves very serious health-related suffering. I am stopping for a few seconds for you to think whether our training and the way the medical system functions trains people to be disease-focused or also to treat suffering. So a few people are writing in the chat, only disease, primarily at the disease, or only at the disease, just from the disease, etc. The response is coming. Thank you very much. This fills me with fear. This fills me with fear because I know that I also will go through a serious illness at some point of time. It's inevitable. I have maybe about 10% of chance that it will be a sudden death. 90% of the chance is that I'll go through, or at least 85% chance is that I'll go through a prolonged illness before I go. My apprehension is not that I will die. I have no problem thinking about that. My apprehension is also not quite that I shall be bedridden and with a disease for a long period of time. Of course, if I have a choice, I don't want it, but there is no choice. That I can accept. What I cannot accept will be, ladies and gentlemen, if at that time you poke me and image me and do so many investigations, all to focus on the disease, while you may not at all care about my suffering, and sometimes actually inflict suffering. In a year, now more than 90,000 medical students join MBBS through 630 odd medical colleges in the country. And you form 100 out of the millions of doctors in the country. And unless we all work together to multiply those numbers, our own loved ones, I myself, and your own loved ones will be at risk of a disease-focused treatment that may actually worsen suffering. Let me share my screen and start with this image of a person who was treated for 1.5 years for cancer, and then had to live with the feeling that someone was putting in a red-hot iron into her mandible and twisting it there. The same person could easily get pain relief for about 10 rupees a day. The duty of the healthcare professional as defined officially in India is this. This is from the Bioethics Unit of Indian Council of Medical Research. It is to mitigate suffering, to cure sometimes, relieve often, and to comfort always. There exists no exception to this rule. So let us start this discussion with a gentle reminder that all along during our treatment, we will focus on the patient primarily and the family secondarily. Of course, we matter. Our staff's well-being matters. If we don't have well-being, we cannot take care of the system. The healthcare system matters. The hospital rules matter. Without them, the patient will suffer. But primarily, the system should not grow so horrendously that the patient gets forgotten and the system does exist for itself. That would be a calamity. I'm sorry that of these, many of the global fellowship participants have gone through this tirade from me several times. But I'll remind you that in our country, more than 29,000 people kill themselves for health-related suffering. That's only the number of people who get into the statistics. Many multiples of numbers will not be getting reported. And for every one of them, 100 people will be trying to kill themselves and failing. So the task is huge. I said the healthcare system may actually inflict suffering. That's in multiple ways, including the horror of procedures without pain relief. It's also catastrophic health expenditure. The numbers are tremendous. 55 million in India a year. Pain relief, leave alone all palliative care, basic pain relief reaches less than 4% of the needy in this country. The WHO ladder has been in existence for 36 years. Even now, less than 4% of the needy get even basic pain relief, including access to step 3 of the ladder. For those who are new to palliative care, my apologies. I am not going into the details of these. But let me add, because that will come. That will come in at least in the third session. That will follow this one. But I will still make the point that if this simple ladder is used with non-opioids and adjuvants in the first step, with the addition of a weak opioid like tramadol in step 2, and with the addition of a strong opioid like morphine, methadone, or fentanyl. With a simple application, at least 3/4 of all cancer pains can be relieved. At least about 75% of cancer pains can be relieved by simple application of the ladder, and it is not a matter of cost. It is not expensive. Among the medicines that I have mentioned, fentanyl is the only one that is very expensive. 1 day of fentanyl therapy, average dose, costs about 150 times that of morphine or methadone. But you also know that the vast majority of corporate hospitals have access only to fentanyl, not to the inexpensive oral morphine. So making sure that we can use the opioids and making sure that we remember the cost of treatment and use the lowest cost, that is the key to progress in this country in the matter of pain relief. And who should do this, friends? People who have gone through palliative care training or any doctor. Use of medicines like oral morphine should be reserved for people with palliative care training or pain management training alone, or should any doctor be able to prescribe it? Can I have some comments by chat?
Sir, can I
Yes,
say,
please.
sir?
Yes.
Sir, right now, I guess, sir, the problem of since the problem of narcotropic drug use is high among the civilians, now the governments are actually going into more and more controlled. Control over this. I guess, sir, a license system might be good, because nowadays rather than the alcoholism, the drug usage, the dope usage has been becoming a threat, and most of the government agencies are trying to argue for larger control. So in government hospitals also, it is very strictly monitored and all. So
Ambu,
some kind of licensing might be good, I guess, sir.
Ambu, thank you very much for the question, for the response. Licensing is another thing. If your hospital has a permission to stock it, or what you call license, today it is just a certificate of approval. If you have it, as superintendent of your hospital, you take the responsibility to keep it securely, use it properly. You don't just dish it out to everybody. But that's not the question, Ambu. My question is about the prescription right. In your hospital, who should be able to prescribe it? Most of the responses came as every doctor. I will modify that. Every doctor who has had basic training. And 5 years from now, 5 years from now that undergraduates are being taught, in those colleges where the curriculum is implemented, every doctor will be able to prescribe it. Ambu totally agreed that the institution will need the protocols, will need the documentation. It should not be irresponsible prescription. That's up to every hospital to follow. Every hospital uses injection morphine, injection pethidine. It is not kept there on a tray in every ward. It's a controlled medicine to be used with controls. So that is undisputed. We will have one session dedicated to opioid access as part of this course. So we will deal with that separately. Ambu makes an important point. Every single one of us has a responsibility not only to make opioids available for pain relief, but also to ensure proper documentation and controlled use. We will never argue for free access, but once it is controlled, once the doctor has studied pain management, you and I have not as a part of MBBS, but tomorrow's medical students will. So Ambu, as the medical superintendent of your hospital, will find that in a few years, the doctors passing out will be able to do this. In any Western European country or in the USA or Canada where abuse is allowed, whatever that is, any doctor is able to prescribe it because as part of their basic medical education, they have learned to use it. Though I am not going to the details, I wanted to introduce this for you to think about and discuss in greater detail when you discuss pain management and when you discuss opioid access. But one thing I mentioned was that 75% of people with cancer pain will get pain relief by the simple application of the ladder. But what about the 25%? We'll have to learn how to handle that 25%. And one of the sessions that you will undergo will be the one on difficult pain, which will deal with the other 25%, what all we can do to treat the pain and the other people who do not respond to simple application of the ladder. But of course, that's only pain. What about other symptoms? Whether it's pain or any other symptom, our aim is to treat the suffering. Any symptom needs to be treated scientifically. Now, that kind of symptom control may not be something that you have learned in your Bailey and Love. Bailey and Love, I don't know about the last 7 years. Till then, it did not say how to medically treat the obstruction of the intestines in a malignant tumor. It talked only about the suck and drip regime and so on, and surgical procedures. So maybe any symptom we will have to approach with the lens of suffering. When I treat an intestinal obstruction, I shouldn't be treating only the obstruction. I should be treating the person. It is persons who suffer, not just bodies. So let us start discussing the how of it by remembering these great humans. Dame Cicely Saunders, who is the founder of Palliative Care Movement, who created the St. Christopher's Hospice in 1965, that long back in London. Dr. Balfour Mount from Canada. Cicely Saunders is no more, but Balfour Mount still lives in Canada. He is the one who gave it the name palliative care. Term palliative care was coined by Balfour Mount. He was the pioneer of palliative care for North America. And Dr. Lucito J. D'Souza, the onco-surgeon from Mumbai, who lives in Mumbai, who brought palliative care to India in the year 1985 in the form of Shanti Avedana Sadan in Mumbai. These are some of the giants on whose shoulders we stand. At some point of time, maybe it will be good at least to Google and read about these people. Going on to the question of what exactly is palliative care. In 1990, when WHO published its 1986 definition of palliative care, it used to be applied only to people whose disease was no longer responsive to curative treatment. Anybody, any comments about this? Is this okay if we restrict palliative care to people who are no longer responsive to curative treatment? Is that fair enough? At least a simple yes or no on the chat box.
No, sir.
No, sir.
Anybody who thinks that palliative care is only for people with incurable illnesses? Not in this group. Absolutely, everybody. So thank you very much. Let us not go away with the thought that it is okay. This, therefore, the WHO themselves redefined it to include all life-threatening illness. This was in 2002, 20 odd years back, and this definition still stands. Are you okay with this? All life-threatening illness?
No, sir.
What's the problem? Hey, challenging WHO. Who is challenging WHO? What do you think? What is fair then?
Sir, I would say like
It's not only about, okay.
we talk about suffering, it can be there in like almost every illness, not it should not be restricted to only the life-threatening illnesses.
Yes.
Is that what Kavin Kumar said? Was it Kavin Kumar who said that?
I'm Sir Dr. Nikhil.
No.
Dr. Nikhil.
Dr. Kavinkumar.
Dr. Nikhil, thank you. Agree. But let me put up another question. maybe not for detailed discussion now, for you to think about what is life? Is it only existing? It's only a beating heart? I hope all of us will define life as something that's not only the basic organ functions, but also something that involves some enjoyment, some contribution to society, some relationships, some interaction.
Right.
If you define it that way, this may be okay, but still, this created the problem. People started defining it life-threatening as only those that will in imminent future cause death. This was unacceptable, and therefore we too old, 21 years old, we would now accept a phrase that is given by the Lancet Commission report of 2017 that palliative care is for prevention and treatment of serious health-related suffering. These are not complete definitions. Long definitions I have not included. Here also it is not the whole sentence. But to Sunil, Amrita, and I, and for many of you, any serious health-related suffering is an indication for palliative care. But arising from that, I have one more question. Is it only for acute chronic disease or not necessarily chronic?
Anybody can unmute and speak.
Yes, comments are coming in. It is for not necessarily chronic. Nobody
It can be a
has,
progressive disease also.
it can be progressive, but not necessarily.
Yes.
Doctor, if you go to the surgical ward and find somebody trying to jump out of the window from a post-operative, and I have seen that. I have seen the patient's wife, assisted by a lot of caregivers, pulling somebody from the window of a 7th floor. That is in a hospital where Sunil and I worked together once for severe pain. And what will you do? Your problem is not chronic. Go and kill yourself if you want to. I am walking away. This question would not be relevant to the countries in which the definitions were created. In Western Europe or the North America, the question may be invalid. Acute pains are treated. Whereas in our country, if we want to practice with integrity, with satisfaction from our work, if we are confronted with any suffering, we should be able to address it. Of course, we don't put that patient on our list and treat that person for 7 years. Maybe that's only for today. That's fine. I believe I should be helping my surgical colleague or anybody with a patient's management if they are in serious health-related suffering. Anyway, just for your information, the WHO definition does not say chronic. It says any life-threatening illness. So no need to restrict it to chronic. In our country, just from 20 diseases, according to the Lancet Commission report, Sri Priya, I hope you will be sharing the presentation with everyone. More than 7 million people from just 20 conditions suffer from serious health-related suffering. Now, if you also count other diseases that are not included in the 20 for which data are not available, and also other situations where there is serious psychosocial suffering, the numbers must be at least 10 million. So we are talking about that kind of numbers, which we are all going to address together. So now I have a question for you. Would you put up your answer in the chat box to this question? Sri Priya, now I understand that we are no longer able to do polls
At
with
the
the
time of
version of
diagnosis.
echo that we have, right?
Yes, sir.
Yeah,
That is
unfortunately.
one drawback we are facing.
Yes. So, honey, let me address you first. Honey, think of me getting some illness. It can be anything. It can be cancer. It can be, if I'm lucky, if I'm not, it can be dementia. It can be a progressive neurological disease, can be Parkinsonism. That disease may take years. And honey, it will be unfair to allow me to suffer through all those years or months and then to give me palliative care only when I am dying at end of life. Honey, you are right. Certainly end of life also should get palliative care.
Oh, got it, sir.
Okay. So, honey, if you are my doctor, I want you to be able to look at my suffering and treat my suffering when you find it. But honey, I'm very glad you gave that answer because that gave me the opportunity to clarify this important point. And most of you have said A or B, which is fine. Officially, the new definition of WHO, that a part of which I showed as for all life-threatening illness, that definition has 9 footnotes, and one of the footnotes officially says that should start at the time of diagnosis. So, thank you. A would be correct. But I have a question. If the doctors take about a month to arrive at my diagnosis, if I am in severe pain during that 1 month prior to the diagnosis, shouldn't I get pain leave? If I am extremely anxious about my suffering, shouldn't I get relief? So, my own personal choice. No, when you said A, that's okay. You are with the WHO. It's not as if it's a wrong answer or anything. But personally, as your patient tomorrow, I want it when my suffering starts. Whenever that is, which may be before diagnosis also.
സാർ പറഞ്ഞോട്ടെ സാറേ.
English.
Sir, actually, I also go with the B, sir. There's one more reason, I guess, sir, because in our country, I mean, even the secondary care is not very much available to people, and the government hospitals are not that much equipped as in the Western countries. Sir, I guess the option B will be the best because that will be the most optimum use of resource also, I guess, sir. From that resource use point also, B might be the best. I think so, sir.
Okay, thank you, Ambu. Thank you for highlighting my point. And please remember that B can be before A, even before the diagnosis. Thank you. And so, the old dictum of palliative care starting only when the disease is no longer responsive to curative treatment doesn't stand. It starts when the suffering starts. If initially there is very little suffering, you go on with disease modifying or potentially curative treatment. But if there is pain or breathlessness or anxiety, you start treating them right there. And as the disease progresses, unless there is a cure in the process, supportive and palliative care comes in. And at some point, disease modifying or potentially curative treatment may become negligible and palliative care becomes more. And earlier, Parul, when I asked a question about when it should start or something, you mentioned in the chat box that it is for caregivers also. Thank you, Parul. Very important point. By definition and by practice, palliative care is not only for the patient, it's also for the family. It's also for those who love him or her. And therefore, support for caregivers continues after death of the patient. How much we can do will depend on how much do we want to do. We are all busy. Parul saying care for the caregivers. Parul, you have hardly any work in the hospital, right? You can spend a lot of time for family? Not necessarily. But you may find a medical social worker. Or in our case, we have volunteers running the bereavement support program almost completely. A monthly get-together self-support program, all that happens. And if we are giving home visit to a patient, once the patient dies, the family gets at least one more visit where they look for pathological grief. So start early and don't stop even if the patient dies. As Parul says, palliative care is only also for caregivers and it has to continue. There may be limits to what we can do, but within that limits, we do what we can. Of course, fundamentally, majority of patients in palliative care have pain as a symptom. So access to pain relief is vitally important. But any symptom has to be managed appropriately, aiming at quality of life. That means if this man in severe breathlessness, like my friend's son-in-law is at the moment in a big hospital, being threatened with an endotracheal tube till death. That's unfair. Just because we have a facility to have ventilators doesn't mean that people should die with on ventilators. Please don't do it to me when my time comes. Don't isolate me. I'm scared. I need to be with people who love me. Let my family stay. May not be a whole crowd, but at least one or two. And if oxygen helps, give it to me. We will discuss other symptoms, including breathlessness later. If oxygen seems to help, we should continue it. If it doesn't seem to help with the breathlessness, you don't treat the pulse oximeter, you treat the person. If it doesn't help him, why continue it? Corticosteroids might help in advanced cancer by reducing peritumor edema. Say, for example, in lung cancer by opening up the airways. And morphine in breathlessness today becomes a drug of choice in many conditions, even COPD. Dr. Ashok Matthew, you studied MBBS only after a few years from me. You and I learned that morphine is contraindicated in breathlessness. But today, it becomes a drug of choice. I wish I had time to tell a few stories. Very recently, I treated one of my teachers who had been on oxygen, high flow oxygen, for more than 2 months. We started 2.5 milligram of morphine 6 hourly, and in 3 days, she came off oxygen. The mechanism will be discussed when we discuss symptom control. But please remember, it is not against the law to withhold or withdraw artificial eye support. A Supreme Court judgment of 2018 acknowledges the importance of withholding and withdrawing artificial eye support. We will talk about that when we discuss end-of-life care. I mentioned symptoms, but of course, please remember that we are not only talking about symptom control. We are also talking about not only physical suffering, but social suffering, spiritual suffering, and emotional suffering. And social in the low and middle income country context involves financial suffering also. That may not take several chapters in the Western textbooks that we study, but in our reality, We know that the treatment destroys generations together. So all these are things to be addressed. How are they to be addressed is something that we will discuss when we talk about organization of palliative care. Why am I asking about him? Let me ask about me. Where are you going to treat me? At the end of life? Home? Okay, thank you. Practically everybody wants to keep me at home, but let me ask you.
It will
Will you
depends
be
on
there? Will
where you
be
want
there?
to be. I will get some consent from your side also, sir, before I decide.
Yes. Thank you. Yes, it's my choice.
Any place which is feasible to patients. It may be.
Yes, but it also depends on you. Because let me ask you, I want to be at home. That's where I belong. But Nikhil says, if things can be managed, how do I manage it? How does my family manages when at 2 o'clock I throw fits? Or when I breathe like this? At that time, what they will do is get an ambulance and rush me to the corporate hospital. And there I am sunk. I'll die on a ventilator. So, home, I totally agree. For the vast majority of people, home is the best place for end of life. Provided you are able to give care at home. Will you be able to make a visit once in a week, at least? Or will you have a facility for emergency visits? If not, maybe not. I had again another of my teachers dying in our institution about 8 months back. She and her son, an oncologist from MD Anderson Cancer Center, they live only 1 kilometer away, but they chose to come and live with us. She said, I feel safe here. I will stay here. I know I am dying. I don't mind dying, but I will stay here. And Ibanila, I'm sorry, I may not be pronouncing your name properly. Ibanila, with the presence of at least one family member, if such a family member is available, absolutely. Hospitals throw family members out. By good God, I want my family member with me. I may have a last message to say. I may just want to say I love you before I go. So that is important. Proper communication. And Amrita, yes, absolutely. Communication has to be good. The family, if they are to manage at home, has to be counseled in how to handle even emergency situations. Very good. Thank you, everybody. But I don't think anybody by choice wants to die in an intensive care unit, and though that is often the reality. What I have tried to do in the time that I had is to say what palliative care is. Not very clearly here. I brought you through several definitions, but highlighting the point that we believe palliative care should be prevention and management of serious health-related suffering. We said that it involves at the commonest problems, control of pain and other symptoms, but not only that, but also evaluation, assessment, and management of social and financial issues, emotional issues, and spiritual issues. And I said that had to start when the suffering starts, which may often be right at the time of diagnosis. And then we said that care should ideally be in the patient's home, if we can get care across to the patient at home, if we can support them. But as Sultana and Sir say, Sultana, never in ICU. Thank you, Sultana. If we have a choice, There may be some situations where you may consider that it's a salvageable situation and you may keep the person. So once in a way that may be an acceptable thing, error to happen, but by choice, no. Nikhil, yes. Many people want to prolong life. I will accept Nikhil's addendum. It depends on the person. I actually had a patient who said, ventilator or whatever, keep me alive till the 24th. My son will arrive on the 24th. I want him to see me alive. We kept the patient on the ICU. We kept the patient on a ventilator. That is that person's choice. So, Nikhil, that's the exceptional patient's choice. Thank you for mentioning that. Yes, the family will want the loved one to live as long as possible. That's where we have to sit down with them and explain what would be the degree of suffering and how we can together relieve the suffering. Yes, so thank you very much. Sunil, we have only 10 minutes for the discussion for taking on any questions. Sunil, can I hand it back to you for discussion?
Okay. I think there is one more question in the chat box from Dr. Priya. If the family insists on ICU care.
Hey, please, course coordinator, make a note. Priya Ramakrishnan asked the most difficult questions. Every faculty member should be cautioned against Priya. Priya, hey, I thought I had beautifully established a case and now you bring up the realities in life. But friends, see what Priya said is the reality. The patient says, let me go. Stop torturing me. Sri Priya, I think we should send them all that article by Sindhu in the Hindu, where
Yes.
Sindhu talks about her dad who kept on saying, don't torture me, don't torture me. And the hospital system insisted on it and it continued. But then families inflict torture. And therefore, I mentioned my son-in-law's, my friend's son-in-law, who is being threatened with intensive care unit right at the moment, only 3 kilometers from me, whom we were treating for about a week, but the time was not enough. We saw them too late. The person himself wants to explore curative treatment more. But eventually, when he came to accept incurability, part of the family is insisting on desperate measures, saying we have started homeopathic treatment. Let us keep him alive till it works. Things like that. So loving family can cause a lot of suffering. Now, who said that? Sorry, Priya. Priya, I am the patient. You have learned medical ethics. Medical ethics. The fundamental overriding principle of medical ethics is autonomy. This is my life. Priya, will you go by my wish or will you go with my family? The answer.
I will go with the patient's wish because
Priya, Priya, you are getting into trouble. You are very correct. You are ethically right. But there is another principle which is not written in books of medical ethics. That is, dead people do not go to court.
Yes.
Living family goes to court.
Exactly.
That's the challenge. We have to live in the real world. The patient is no longer able to say anything. Or they may say, no, get me out. But the family forces you to. Very difficult situation. The only answer is to start early, talk to the family. And this, remember, this is not about somebody else. This may be with all of us in our own families. You may have two kinds of love. One is a selfish kind of love, where you feel, I can't let my mom go. I can't live without my dad. That is a selfish kind of love. The more unselfish kind of love would be, poor thing, he's suffering so much, let him go. I will somehow manage. So these points can be made only if we start the discussion early. In the real world, when the situation arises, every doctor goes with what the family forces. Priya, you also may have been forced to do that. You may have no choice. Advanced directive, Biju, advanced directive, shall we discuss it on the session on end of life? For discussion in detail, as I said, advanced medical directive is something that is approved by the Supreme Court of India in 2008. Kamal Shigli, I agree. That's the way it should be, Kamal. Thank you. If we lived in a fair world, what's good for me should be done when I am the patient, not what my family wants if that's in conflict with what I want, so long as I am in possession of my faculties. I agree. But that means we have to together do a lot of public education. Death is something that nobody talks about nowadays, especially since the last 2 generations. Death is a stranger to be feared. And unless we bring another 2022 Lancet Commission makes a recommendation, bring death back to life, meaning let death get discussed. But certainly, friends, we'll discuss more about end-of-life care at another occasion. Is there any question about any aspect of what I talked about?
Sir, I have one doubt, sir.
Yes.
Sir, actually, there are 4 principles. No, sir, as you told, autonomy and these things, sir. But my doubt is, sir, at the end of the life, I mean, when a patient is in an advanced carcinoma, sir, his mental health might be also in trouble. No, so at that time, if that patient is making a choice based on his autonomy, and we go with that, will that be doing harm to him? So that is, if due to an advanced disease, the patient's mental health is also deranged, will going with the patient's autonomy contradict the idea of non-malfeasance, sir? So in that kind of situation, sir, like mental health.
Ambu, thank you. The question is very clear. The patient's autonomy is valid only so long as the patient is mentally competent, unless he or she has left advanced medical directives. The reason why I have put it down in writing and got my family to agree and actually got my nephew to sign as a witness is because I realize that I may not be mentally competent to take that decision. So Ambu, as you, the treating physician, if you decide that this gentleman is no longer mentally competent to take an intelligent decision, the autonomy immediately gets transferred to the next of kin. But there the problems arise. Next of kin may be 4 children, 2 pulling this way and 2 pulling the other way. Which problem can be resolved only with continued discussions and whenever possible by starting these discussions early. So, Biju, advanced directive I have answered.
Radha Ganeshan. One of our relatives is recently diagnosed, a week ago diagnosed with the gallbladder cancer with a 31-year-old female with the ductal carcinoma as well as lymph node metastasis. They are in the process of diagnosis because biopsy is sent. She is admitted in the ward and all. Pain relief medication started. So now what is it? How you said we have to start the palliative care at the time of diagnosis now itself, but how the relatives will be explained about palliative care? They may want full treatment because aggressive treatment for the cancer, everything they wanted to start. So does it go together parallelly, aggressive treatment as well as the pain relief management together?
Dr. Radha, thank you. Our team, so Sunil and colleagues, and Sri Priya and everybody together did 2 courses on introduction to palliative care for oncologists. Together, around 75 oncologists around the country got basic palliative care education. They wanted it, mind you. They asked for it, attended it. Dr. Radha, your question will be best answered by how they will practice. When they start the first conversation, saying, of course, there will be the communication of bad news. And usually that should be followed by a question. I know I gave you bad news. You are looking devastated. Tell me, what's your biggest concern? And a lot of people may say, I don't mind dying, but I don't want the suffering. And you, the oncologist or the neurologist, should be able to explain that as when pain or any suffering happens, we will try to relieve it. And at any point of time, if help is needed, we have specialist doctors in palliative care. Palliative care is for any time of the disease. Even now, if you have pain or other serious suffering, they will come in and help. If that explanation is given by the treating doctor, then the whole problem is solved most of the time. The problem is, after a year, you go and say palliative care, and many people associate it with death and dying. They are not willing to accept it. So this is a task that we have to do. Our task is not only to treat patients, our task is also to be advocate. 4 centuries back, Paracelsus said, the physicians are the natural attorneys for the suffering. That is something that we all should be doing. Jagrati, I know you do a lot of advocacy work, going around talking to a lot of people. Yes, Jagrati.
The maximum I'm facing here, all the doctors, they refer it to me at the end of life when nothing can be, sir, they cannot do anything. That's where they refer. So that job becomes very difficult. And I talk to the doctors. I always say that I'm working in alliance with you. We are partner. So it should be right at the time of the diagnosis. So I'm doing really, sir, working hard to explain it to them, sir. I get all the patients end of life. All patients, sir.
Thank you, Jagrati. I know Ravi also has, wait a minute, Ravi also has raised his hand, and Sunil will get very angry now. The time allotted to me is over. Now is the time for the case presentation. But quickly, taking on Jagrati. Yes, Jagrati, that is the cross that we all bear. But remember, at least the patients on end-of-life care are being referred now. Yes. Nobody was being referred earlier. Things are changing, and it will depend a lot on our advocacy. Dr. Ravi, before Sunil shuts me up, you please ask the last question.
Sir, it's not a question, but as the advocacy which has been told, even as Kubler-Ross says, 5 stages of grief, even the treating oncologist will be in the bargaining phase that I should treat the patient, it should be get cured of, why should I refer to a palliative care physician? So in that egoistic and in the conflicts area, the referral are being inhibitions. That's what I want to.
Ravi, hey, Ramesh, you are raising the hand. Don't raise it to me, raise it to Sunil. It will be up to him. He's the big boss. Ravi, medical science has still not invented the cure for ego. We all have it. We all live with it. And especially when a lot of medical knowledge goes in, there will be a question of ego. But it's not only ego. With a lot of people, it's also ignorance, thinking that palliative care is only for the dying. But things are changing. When you attend a meeting at the National Cancer Grid, you feel so enthusiastic because a lot of the younger generation of oncologists are embracing the principles of palliative care, but please do not expect change to happen overnight. We will have to work hard to effect that change. Sunil?
Yes, Dr. Ramesh, you can take that question. So,
Ramesh, please, Sunil has given us permission to continue.
Thank you, sir. I'm working in a rural hospital. I have seen that mostly in these situations, patient is not a party to even to know about what is his situation. Usually it is somebody who is a little literate, who is a party to discussions and other. Many times the patient himself or herself is not a party to what is the diagnosis, what is the course of illness.
Dr. Ramesh, you said you are working in a rural area. That's a enormous building behind you in the screensaver.
So that's a medical college, sir. It's a setup in a rural area.
Okay. Yes, Dr. Ramesh, thank you. That's a very common phenomenon in our country. Doctors do not talk to patients. Doctors talk about the patient to the family. There are several advantages. They are less likely to break down and cry. And even there, most people say, hey, if the patient's wife is with him, hey, aren't there any men around? Isn't that common? As if women cannot be bold. My good God, are you sure that men are braver than women? They may cry easier. Jagrati is protesting. But that's the practice. That's the practice, Dr. Ramesh, we are going to change. A culture that is established over centuries cannot be changed overnight. But when, as I said, these oncologists and neurologists and pulmonologists have all gone, a significant number have gone through the training. But when their number rises from dozens to hundreds, we will feel a difference. And I hope that difference will not be too late for me. I'm sure there are many questions in the chat. Sri Priya, if you will copy the questions and keep it, maybe we can answer them with emails later.
Sure, sir. We'll do that.
Thank you.
Thank you, sir.
okay. So,
Sunil, can I leave in another 5 minutes?
Yeah, okay, sir.
No, did you really want me?
Sir,
Okay, let me see.
Possible,
Okay. I'll try to stay for as long as I can after making one call. Thank you. Thank you, Nadeem. Thank you, everybody.
In summary, we talked about the various definitions of palliative care, and you can see how palliative care is evolving from the first definition of palliative care is only for those diseases when curative treatment is not possible. And now it has come to a stage where palliative care is for treatment and prevention of serious health-related suffering. So we should think where palliative care is going, and that's the importance of integrating palliative care into every aspects of healthcare. So I think that was one of the most important points. And I think we can move on to the patient story. So which will be presented by Dr. Amrita, who is the palliative care physician and the clinical head at the Trivandrum Institute of Palliative Sciences.
Thank you, sir.
Good evening, all. Am I audible?
Yes,
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
First of all, thank you, Palliative, for giving me this opportunity to do the patient story. So I'm quickly moving on to the patient story. So presenting a 10-year-old girl who was diagnosed with super refractory status epilepticus due to the febrile infection related epileptic syndrome with sequelae. Next. So when she presented to us, she had seizures since 11 months. She had pressure zones and she was on tracheostomy since 10 months with secretions. Moving on to the history of illness, she had a history of high-grade fever associated with headache over the bitemporal region and fatigue 11 months back, which was evaluated at different hospitals, but fever not subsided. And into 2020, she developed seizures of multiple seminology. She was referred to the Sri Chitra Institute of Medical Science in July, and her GCS score was E1, V1, M1, and was on mechanical ventilation and on multiple anti-epileptic infusions. There was no significant improvement, and for control of non-convulsive status epilepticus, she was given multiple cycles of intravenous midazolam and thiopentone. The frequency of focal electrographic seizures slightly improved. Mechanical ventilator support slowly weaned off and was on room air since mid of December 2020, and her GCS improved to E4, V1, M4. She had occasional brief episodes of generalized tonic-clonic seizures, and she was transferred to a pediatric center. So it was from there that she was shifted to our center. So on examination, the patient was drowsy. There was spontaneous eye opening, and response to pain was there. Feeding was through the Riles tube, and she had contractures of both knee with hand deformities, and pressure zones were also there. And as I already mentioned, she was on tracheostomy, and all other systems were within the normal limits. So regarding the treatment and investigations, MRI revealed gyral edema with no other abnormalities, and EEG was suggestive of non-convulsive status epilepticus. MRI brain, which was repeated in 2021, showed bilateral independent periodic discharges and brief focal bihemispheric electrographic seizures with no clinical correlate or no NCSC. So direct Coombs test was negative, and autoimmune encephalitis profile was negative. CSF viral encephalitis profile was negative, and TB NAT was negative. Many other investigations to rule out the fever was also done. So moving on to the psychosocial aspects, the child is primarily taken care by her mother and maternal grandparents. Her father, who when he came to know about his daughter's illness, he committed suicide in the hospital premises, and her mother was undergoing treatment for mental health issues. And the treating psychiatrist, owing to her condition, has suggested her hospitalization, but which she was unable to make, and she was presently on oral antidepressants. What she wanted really was to get her child back, and she also had suicidal ideation. So after she had an younger daughter also who died 2 days after the delivery. And currently she was running from hospital to hospital in search of a better care for her daughter. She was very spiritual and was busy doing rituals to save her daughter. Priya, next slide.
I had to wait. Is it
you.
visible now?
Yes, thank you. So moving on to the medications, I'm not going to read all this. She was on a whole lot of anti-epileptic drugs. Tyronome was also there, and vitamins. Yes, next slide. So the main concerns that there was regarding the seizures and the recovery. So to summarize, this was a 10-year-old child who was presented with fires, now bedridden and not responding to verbal stimulation. She was on Ryle's tube, Foley's catheter and tracheostomy, had contractures of knee joints, not moving body parts by herself, and mother was expecting the child will be recovered soon. So the discussion points would be, does this patient come under the purview of palliative care? What are the sufferings the patient and family is going through? How can we help them? And what psychological support can we provide to them? Thank you.
So thank you, Amrita. So we have a 10-year-old child who is diagnosed with fires, and her main problem is recurrent seizures, and she is drowsy. And there are a lot of psychosocial issues in the family, and the mother actually is willing to do anything to get her child back. So in between, the father of the child committed suicide by knowing the diagnosis and thinking that she may not recover. So what Amrita is asking a few questions to us. So if anybody has a, so this is a 10-year-old child with seizures. So does this child come under purview of palliative care? So that is the first question. Anybody can answer this, and please justify your answer also. Why should child come under palliative care?
Sir, I'm Dr. Kavin here. So, as per our palliative care focus, so any health suffering will come under irrespective of the case of disease, seizure, cancer, any illness related suffering. Along with this, in this case, not only the child who is suffering, along with the child, the patient and entire family background is suffering from this single illness. Even though the mother had some psychiatric, she had some previous history of psychiatric illness, but this had made her more worrying about this illness, and it might have occurred with her. So we have to, it comes under the purview of the.
Okay, thank you. So I see a lot of chats which says yes, she definitely comes under palliative care, and many of you use she is suffering from serious health-related suffering. So, sir, do you want to add anything else in this question?
Sunil, please continue. If I have something to add, I'll jump in at that time.
So, what are the suffering that patient and family is going through? So, anybody can please unmute and speak.
Both emotional and financial also. So many medication admitted in the hospital, and financial suffering also family is going through, and the father is committed suicide. That also affected psychologically. Mother is already affected by depression. So someone to support the baby, understand the baby's child situation. So even the doctors who are taking care of them also may be undergoing a kind of like caregivers, they are also undergoing suffering.
Yes. Anybody else want to speak? I see a lot of comments in the chat. So, suffering of child and family, financial suffering, psychosocial suffering, emotional suffering, physical suffering, loss of husband, financial and psychological problems of mother. Yeah, physical, economic, emotional, psychological, social. 10-year-old girl might not understand her illness, mortality, scary for child, especially having lost her father. Yeah, that's also important. Sir, in this slide showed that the person is not only suffering from the physical problems, but he has showed us the four circles: physical, psychological, social and financial, and spiritual aspects. So whenever we look at the patient, we should try to cover all these aspects of suffering. But I would also like to concentrate on the psychological aspects of that mother, because she lost her husband. She lost a child when the child was 2 years or 2 days. So this child is in a very serious condition. So she is going through grief and probably through anticipatory grief. So many uh, she's going through severe psychological stress. So I think that is one of the important points that we have to understand from this story. How can we help them? So many of you might be working in many hospitals, and suppose if this child comes to you for palliative care, how do you help this family?
For
There is
this
definitely need
child,
for a mother to be supported mentally, and emotional support to the mother should be given.
Yeah.
For such a family, financial support will be very, very important to go for all other kinds of supports. I mean, even if they need a counselor or proper medication treatment and going to the medical facility for all those things, and even there is no earning member in the family, so lots of those aspects will be there.
Okay. All of you or most of you have talked about the financial problems that family is going through. So I just want to understand if this patient comes to your family, is there some way that your hospital will be able to assist them financially?
So can we
hospital.
think of some?
Yeah.
So can we
Hello?
think of some fundraising?
Okay. Yeah. That's a good idea.
Sometimes what we do is we all get together. That's a very rudimentary way of the doctors. Many of times have done that, or in our part, at least where we stay. So that is what we do. Then we also contact many NGOs like Hans Foundation, and sometimes they help out, and that is necessary. That's sort of financial part. What is more imperative is how we are going to deal with the social support this mother especially severely needs at this stage. So that sometimes our hospitals are totally lacking in taking care of this aspect. We take care of the medical suffering. That is a little difficult.
Yes. As doctors, we mainly or most of the times we can escape by looking at the physical aspect of the patient. But rest we will give it to the medical social worker. But I think um, as treating physician or human being, we should also have the responsibility to give some inputs on what all can be done. because sometimes there may not be MSW. I know there are many hospitals where only the doctor will be there. So and the medical social worker will be there only in, I think, in big hospitals, but in our unit we have 10 or more than 10 medical social workers, but it will not be there everywhere. So as palliative care physician, I think we also have a role uh, in looking at the whole person by or we have to concentrate in the total suffering. So many of you have come up with many suggestions like crowdfunding. Maybe even some of you might be taking money from your hand, contacting other NGO. So this is something which you have to think of how you will be able to help if a patient like this comes. And I see that somebody has talked about the cost-effective medication. Yeah, that's also very correct because we know that for treating pain, many of the doctors prescribe Andanin patches or buprenorphine patches, which is very costly compared to the cheaper medications like morphine. So if you prescribe Fentanyl patch or buprenorphine patch for a patient who is very poor, then that that is justifiable. So that's also a way of giving financial support for the patient and family. So there are a lot of things that we can do, but all of us have to try. Yeah, and I see the last question is specifically on psychological support for the family or for the mother, I think. So how are we going to provide psychological support for the mother?
She may feel helplessness. We should assure that we are there for her to make her child to be well and her family to be comfortable at all possible ways.
Yes, yes, that's correct. Anything else?
I think
Doctor.
listening to her, allowing her to express her grief, because she might need to talk. So allowing her to talk and being a good listener method for her to come out with her problems, because she might not be expressing her suffering.
Yeah, Sairo madam talks about screen her for depression, and she might have anxiety. So we have to manage it properly. Yeah, Dr. Raju says, assure her about keeping the kid free from avoidable suffering. Yes, somebody is
Sir, I also believe that sir, I also believe that when the patient are able to talk to other bystanders, they are more able to understand what is going on. For example, in the wards and all, when a patient is suffering from the same disease, the bystanders are able to comfort each other and provide more support. Like they can give advice on how they approach a particular situation or a hardship. So I think support groups and other such meetings can also be conducted to help them understand that they're not the only ones suffering, and there are many different approaches that others can also take.
Yes, that's an important point. Support groups where the people talk about their suffering and how they cope with the problem that they have, so that the patients will understand about how we can also manage our situation. So that's an important point. And
we can connect her. We can connect her to some NGOs from where she can get financial support.
Yes. Um,
Sunil,
yes,
can
sir.
I add something?
Yeah.
Khushbu, this is not the only patient that you are going to have with financial issues, major social, psychological issues, social issues. How much time will you spend getting financial support for this patient? Sorry, I'm putting you on a spot, but just for a minute, let me share my screen and show you just one image. To conclude, I know it is time to conclude the session. I'm talking about something that's ideal, that will take care of Khushbu's problem. Not only Khushbu's, so many people brought out so many issues. My God, what an interactive group. This may sound idealistic, but it's not very difficult. We are trying to do everything. There's a limit to our ability. As more and more treating physicians embrace the principles of palliative care, naturally many problems will be taken care of. But this is not only about palliative care unit. In the regional cancer center in Trivandrum, an organization has been given a room and a desk. They are called Ashraya. They're there for the patients, for everything. So where should I take this paper? It may be directing the patient. It may be telling them, giving them important information. It's also about connecting them with social organization. In the chat box, many people mentioned the government schemes. How would this poor woman access those schemes? And this is where Dr. Khushbu will be too busy to handle all this. And someday, when Dr. Khushbu, you are the medical director for your institution, please open the door to non-government organizations to come in with rules, with guiding rules, and they will do wonders. There will be problems. Dr. Sairu Philip has engaged a whole community in a city to help with palliative care. But that is not only applicable to palliative care. This is about healthcare. So thank you for that question and the comments, but also about several other very important comments came in. Sure, we won't have time for that. Dr. Junida Aris is talking about respite care. What a beautiful concept. Who will come in there in the place of that mother? She will burn herself out. So desperately needed. The only solution will be that social support system with the involvement of non-government organizations. And psychological support, not only to the patient, but also to the mother. But also important point was made. Psychological support is not only about talking nicely to them and listening. It's also about identifying significant, treatable psychiatric diseases that occur, including treatable depression. It may be there. She doesn't have the luxury of thinking about her own suffering, but she is burning herself out. And Amrita mentioned in her case presentation on an important point. She herself was having suicidal thoughts. That's not something that she can control. Talking nicely to them is not the only solution. So, Amrita, you gave us a handful of problems with your first case. That is quite an overwhelming case. I know that you are struggling with this patient right now. And therefore, I've overshot time by 3 minutes. These people are going to be very annoyed with me. But that final point, you cannot always succeed. Let us accept this. Dr. Ibanila, Nikhil, Dr. Venkatesan, Dr. Nishad, none of you is God Almighty. You cannot solve all problems. And we have to accept that. At the end of the day, we should be able to get to bed and get our sleep, comforted by the thought that I am only a human being. I have done my best. That's all that matters. You cannot solve all problems, but we have a duty to try. Today, the medical system is refusing to see any of that suffering. And what you do by confronting the issue, doing your best, that is phenomenal. And that's all that we can do. Thank you. Back to you, Sunil.
Thank you, sir. I know there will be many more comments because all of you are very interested in palliative care, and many suggestions are also coming. And Amruta says we did optimize our medication to most needy ones, address mother concerns in multiple sessions. Our MSW facilitated fundraising for the family and facilitated psychiatric consultation. Yet a lot more to do. Yeah, thank you, Amruta. So I think we have to stop here now. So thank you, sir, for enlightening us with the importance of palliative care and the important aspects in palliative care, and also for telling us about the evolution of palliative care during the years. And thank you, Amrita, for that wonderful presentation. And thank you all for being interactive. So we'll see you on Wednesday with the session on pain. Thank you, everybody.
Thank you everyone
And
for
Good
joining.
night. Good
Thank
night,
you,
everybody.
If anybody faces any problem in logging in or any other technical problems, please contact Priya. She is an experienced person because she has conducted many courses like this. So she will be able to help you. Thank you, Priya.
Thank you.
Can I just ask a query? What is the long-term prognosis of this patient? I mean, what should be communicated to the mother as to the child's future?
So from the pediatric neurologist, what was communicated as prognosis is not good. And that was what is being communicated both from the neurology center as well as from the pediatric neurologist. But after a year, patient is still alive, and we heard that she has little improved.
So, I mean, how do we take a call on how long the treatment continues, given the child is only 10 years? Are we prolonging the suffering of the child, or I mean, like sir had said initially that we should not be prolonging the suffering of the child. So, how do we take a call in a
Yes,
state like this?
There are various factors which we need to consider. As a 10-year-old child, she will not be able to express her wish, or she is not in a situation to understand. So it will be the parents along with the treating team who will need to take a shared decision. It will not be a decision of one doctor, or it will not be the decision of her mother. I think all of us has to sit together and talk. And this will not be in a session. It takes multiple sessions to come to a common understanding and the goals there.
And the mother is aware of the prognosis.
Mother is aware of the prognosis, but she is hoping that she will come back.
Right. Thank you so much.
Yeah.
Because that knowing the prognosis will also worsen her emotional trauma even more, knowing, because she's already lost one child. Thank you so much.
Yeah. Priya?
Thank you, Sunil sir, and I wish to thank Dr. Rajagopal for enlightening this cohort, actually blessing this cohort with his presence for the first session. And believing that we have started for a wonderful course, sessions of 20 sessions of mutual learning, unlearning and relearning with a positive spirit. This is Sri Priya along with Dr. Sunil Kumar and Mr. Anup signing off from the Tips Eco Hub. See you in the next session with another interesting topic and yet another eminent faculty. Till then, everyone, take care, stay safe, be happy. Bye-bye.
Priya, you should remove your mask.
I hope. Okay, sir. I was just reluctant because Anup was sitting beside me and I thought that I should not be someone who gives away things. I am always fond of taking in things, not giving away much easily. Okay. So thank you everyone for joining in. See you in the next session. Take care. Bye-bye.
Thank you.
Thank
Bye.
you. Bye.
Thank you. Bye.